So digressing a little bit, radium-223. So we know that has a survival benefit. We know it is a calcium mimetic agent. We know it's bone targeting therapy. We know, however, that, again, 90% of patients have bone mets, but we also probably know that a number of them also have microscopic disease in the soft tissue. So Neal, I know you've used a ton of Xofigo as have I. So when you have that symptomatic CRPC M1 patient that you believe is a good candidate for possibly giving radium-223, so like Oliver said, we know it's a 5-minute injection. We know it's approved for 6 doses, 4 weeks apart. Do you also concomitantly manipulate the androgen axis when you give Xofigo?
Mm-hmm. Yeah, so actually it's about a 45-second to 1-minute injection. I actually haven't discussed this with Oliver, but I know that Oliver and I were both competing to give the first dose post-FDA approval, and I just squeaked him out just by a little bit. But he did all the basic science work and all the good work on it. So, but anyway, so it's been great, and so we have used it. And to answer your question, I do use it concomitantly with both enzalutamide and abiraterone. Now, there is no significant body of literature out there at all, and in fact, there are investigator-initiated trials that are ongoing right now. I'm participating in one of those, and I think those will be very important in small volumes to look at just safety tolerability. I think mechanistically, because there's such distinct mechanisms of action, I don't anticipate that there will be any tolerability issues. I think one of the more interesting questions that we've looked at now, thanks to Oliver in the Alsimca trial, is it was given to patients both prior to docetaxel and after docetaxel. And we actually see, if you do that post hoc analysis, that the patients who received it prior to docetaxel, their survival benefit was actually much higher than in the conglomerate look at the totality of the overall survival benefit. So we are pretty proactive in trying to look at it appropriately in the setting of symptomatic M1 CRPC, symptomatic bone mets, and have to judge that in terms of using docetaxel versus giving radium-223 first. Now, the one thing about it is it's a once every 4 weeks, and it's a 6-month course. So we want to time it correctly and not miss giving docetaxel appropriately, but we're very proactive as urologists to do that. Now, one of the things Phillippa said, which I thought was great, is we're not abandoning our patient at all when we refer them to the radiation oncologist or the nuclear medicine radiologist who has to give it. You have to have an NRC licensure. It's just more integrative multidisciplinary care. And it's great because it's more team approach. It's getting the rad onc or the nuke med working with us, with the med onc together. And the beauty of radium-223, as Oliver said, is, and Ken, I think you said it too, is you'll oftentimes see amelioration of pain, survival benefit, excellent tolerability because it's past enteric pathway, not renal or hepatic metabolism. And if you think about timing it appropriately, you'll still be able to administer docetaxel. Along the way, we're giving, to answer your initial question, we are giving concomitant oral hormonal therapies.
I mean, would you agree with that? I mean, just from a physiologic standpoint of where we think these cells are hiding out. We know they're in bone, obviously. So the question is, do we also need, because again, this therapy is going to take 6 months. Do we need to be doing something at the same time from mechanistic action?
I mean, I totally agree with what Neal said regarding radium-223. The patient that springs to mind for me is the patient who has this widespread bony pain. But I think it's key to, again, examine the patient because some patients have very pinpoint pain. They may say, I've got pain right here at this point in my neck. And I think we mustn't forget that for those patients, they can still have symptomatic relief from targeted palliative radiotherapy as well. I still believe there is a role for that in the right patient for symptom control, but I think RAD-223 in the setting of widespread bony pain can be phenomenally helpful.
And I think again, we've not touched on this, but this is another agent, just like Sapilocel T, which is a little bit confounding for our patients, is that it does not have a dramatic PSA effect. And again, I think we have bred this population of I've called PSA addicts, if you will. The engineers are always the worst. No offense to any engineers out there, but you know, they live and die on these PSAs. And I think, again, that to me becomes a very big part of the therapeutic discussion, is to really emphasize that point.
Well, and educate that point too. You know, we tell our patients, you know, there are treatments out there that will lower your PSA but probably not change your survival, or there are medications out there that will improve your survival but may not change your PSA much. And when they understand that, it gives them some comfort to say, look, you know, our goal is to have you live a really long time, a great quality of life, and it doesn't hinge so much on PSA at this point.
You know, one of the things I think that's fascinating is if we look back at this moment in time, 2014, and we jump ahead for 5 years, I think we're going to be moving beyond this sort of sequential era. You know, right now we have drug A and then drug B and then drug C. But we really are already starting to combine these drugs. You know, one of the other agents that doesn't affect PSA is sickle cell T, but it prolongs survival. Well, what am I doing in my practice? Bringing in with the hormonal therapy and thinking a lot about the enzalutamide with not the steroid involved, and being able to use a combination with radium, be able to combine it either with enzalutamide or with abiraterone. And we're not really there yet in terms of the data. But boy, we're going to get there.
Right.
I feel confident we're going to get there.
You know, and that's, you know.